We're going to now move on, and I think, building on this first session, get a little bit more focus on three countries that have very ambitious and impressive serosurveillance efforts. So we have an entirely virtual panel now, which is why I'm moderating, and so. I'd like to just briefly introduce our three panelists. First is Dr. Olav Hungnes, who's a virologist in the Department of Virology at Norwegian Institute of Public Health, who, as Maria mentioned, has been a very prominent actor both nationally and working with WHO. For many years, beginning in SARS back in 2003, but who's been working on molecular diagnostics and molecular epi of influenza viruses since 1996. Very welcome to you, Olav, and thank you for joining us from Norway. We have Dr. Hans Zeiger, who's a medical microbiologist and head of the Department of Bloodborne Infections at Sanquin. This is an organization that provides blood services across the Netherlands. He leads scientific research in the fields of blood transfusion, medicine, and immunology. He's also an emeritus professor of bloodborne infections at the University of Amsterdam. And in addition, we have Dr. Helen Ward, who is a clinical professor of public health at Imperial College London, and senior investigator at the National Institute for Health and Care Research. Her research is on the epidemiology and control of infectious diseases, including HIV, sexually transmitted infections, and SARS-CoV-2. So with that, welcome to all three of you. Thank you so much for joining us in the afternoon. You've avoided some very cold weather in Montreal, but we're very much looking forward to your remarks. And we will begin with Olav, if we can. Please.
Thank you very much, and thank you for inviting me to this very, very distinguished meeting. And I feel that I will try and share my screen now. Host disabled participant screen sharing, it says. Could somebody help with that?
Yeah, we should be enabling you. Yep, you should be enabled now.
Thank you. Okay, I will do. I wonder if you can see my screen now.
No,
can you?
We're not seeing your screen at the moment.
Okay. Let's go to. Let's see. So what are you seeing now?
Sorry? If you can go to full screen, Olav, then I think we will have it. Okay, we've got you up.
Okay, and it's the presenter's mode or the full screen?
This is perfect.
Okay, thank you. So what I'm presenting is kind of a very simplistic way to do seroepidemiology, but it has sort of proved the test of time that we have been able to sustain it for a very long time and in a consistent manner, and that is probably the main virtue of this way to do the serosurveys. So this is things that started with my former colleague and kind of my idol in a way, Professor Lars Hoheim, back in the late 70s. And he did this just in time to capture the emergence of the almost pandemic of the Russian flu in 1977-78. So the scheme is to solicit from the laboratories in Norway residual anonymized sera from hospital labs, and those are irreversibly anonymized. So by this we get all country coverage, we get all ages represented in demographic proportions, and they are anonymized, and we get only information about the sex, the birth year, the sampling time approximately or exactly, and county of residence. So of course, not things that we would like to have, like vaccination status, which the laboratory wouldn't have. And they are collected annually in August, and approximately 120 per county in different age group. Those are the old counties. We are a little fewer. There has been some mergers, but we end up with like around 2,000 sera in each of these annual collections. And the antigens for influenza that we test against is the vaccine strains, the old and the new, and other relevant antigenic variants. So we typically analyze for 4 to 6 antigens annually. So the objectives that we aim to meet with this is to do some retrospective assessment of the extent of virus circulation by strain, by age group, and by region. We also are interested in assessing the immunity and epidemic potential in the future, and that could be annual between the different antigenic variants of the seasonal viruses, but also special cases to assess risk of emergence of spread of novel viruses. And we are trying to use this as best as we can to inform the WHO vaccine composition process for influenza. And that can be, for instance, the pattern of human antibody reactivity to different virus strains that is turning out, and it's getting more and more attention, that this may be different from the ferret antibodies that are used for antigenic characterization in the vaccine update processes. So, as an example, from the very beginning of this program was when this Russian flu H1N1 virus emerged. That was a re-emergence of the viruses that were seasonal before the Asian flu pandemic in 1957, and they were swept away back then. But then they re-emerged in mysterious ways in the late 1970s. And of course, then older people would have immunity to that, but younger people wouldn't, and that was very well reflected. We have in the blue here to the left are sera from 77, the year before, and then in 78, the year after, and you see that the big increase in seropositivity was in the younger age group, those that age band that were born after 1957, and very little impact in the other ones. That was an example of that, how we can assess by this what has been going on. And for the assessment of the risk of spread of viruses, sort of what kind of immunity the population has to a novel virus, this is an example that there was a novel swine virus that was starting to cause a lot of zoonotic events in the US in 2011 and 2012, typically in state fairs, where there was exposure between pigs and children and so on. And there was a striking number of such zoonotic cases, especially in 2012. And the question came up, was this a virus that could spark a pandemic? And risk assessments were done like in the US with the IRAT tool. And we thought, knowing that this actual virus actually had its hemagglutinin from spillover from humans in the mid-1990s, that maybe there was immunity against this because people had been exposed to a similar human virus. So we did the study, and we found that in the age groups that were around in the 1990s, that was a good seropositivity to this swine virus. And And we saw also, when we looked back at the serology data from the 1990s, that this virus is similar to these viruses spilled over into the pigs, that we had good and increasing immunity during those years in approximately the same age bands. So because of this, and some other publication, they redid the risk assessment in the RET tool, and as I marked in the circle here, that the risk assessment was taken down a bit for this virus. So we felt that it was a useful way to apply our zero epidemiology program. We are also trying to make us useful for the WHO vaccine strain selection, and we can show that how the immunity is different in different age groups, and shown here in a very simplistic way is that there is a connection between the amount of sort of the proportion of people who have protective antibody in the summer and the impact of that virus in the subsequent winter in the different for the different, and we see that these profiles are very different for the different influenza viruses. And for this year, we also, as another example of the utility of this, is that we are getting to analyze the variants against a lot of human sera, and we can inform that, for instance, the H1N1 virus, the ones in blue there, the two last variants, the prior and the current vaccine virus, in the ferrets, you can't tell much difference there, but it's very clear that in humans there is a big difference between those viruses in terms of antibody reactivity. And it's the opposite way from the H3N2 viruses, that they seem very different when you look at them through the glasses of ferret anti-sera. But the human anti-sera, they don't care if it's one or the other, apparently. I think this is the things that is useful for WHO vaccine expert group. But the wide sort of the big view of the things that you're doing is that we can follow the patterns over many years, and this is not serology. This is just all-cause mortality and the extent in the clinical surveillance of many seasons, and also the viruses that are predominant in those different seasons from other arms of our surveillance. And you can see that it's the influenza A, H3N2 that is making the big splash, and that in a large part of this period, there was kind of alternating influenza B and influenza A seasons, but that this hasn't been always the case, and it's sort of varying. And if you took that as the arrows are the major seasons or dominance, and then you can see at the antibody in the subsequent season that we see this is correlating very well. We see also that the different influenza A viruses have very different patterns. That's the H3 that was making the big epidemics is going up and down quite substantially, and that the Russian flu that emerged in 77 actually was playing a second violin role here and didn't really do very much, and it was kind of also easily eliminated with the emergence of the 2009 pandemic H1N1 virus, which kind of took a role more side by side with the H3N2, also in the immunological perspective. Similarly, for influenza B, that the patterns, the large-scale patterns have changed very much over the time that we have been able to survey them. You know, that we had big epidemics in the 80s and in the 90s, and then there were those two different lineages, the Yamagata lineage and the Victoria lineage, emerging in the late 80s, and that the Victoria lineage disappeared everywhere but in China in the 1990s, and then they re-emerged in the early 2000s, and how this impacted the patterns epidemiologically, but also immunologically. It's very interesting, but I will not go into detail here. But these are things that we can follow when we have this going for so many years. Of course, we have also been repurposing this for other pathogens. So we have been doing this for, or other people in my department have been doing it over the years for poliovirus, for rubella and measles. And of course, with COVID pandemic emergence, we were among the first in Norway, or the first in Norway, to actually start looking at zero prevalence for the new virus. And we had the first panel going in April and May, and then a second one in August. So we did some extra samplings there so that we could follow, just like we heard also yesterday, how little impact this virus actually had in the population until the emergence of Omicron. That was actually when the pandemic hit Norway for serious. In all those instances, we have seen beautiful complementation with this very simplistic residual sera approach, and also other more sophisticated with much more concrete data from the donors. And the complementation has been very good. And they can be mutually supportive. That the cohort data that have very good information about exposure could corroborate the interpretation of specific antibody profiles that we observed in the anonymized residual sera. And conversely, that we could provide larger numbers and representation for age groups that were difficult to get in those cohorts. So our approach, it's very low cost, it's legally much less demanding than others more sophisticated approaches, and may reach wider age group. And we have proven long-term sustainability through passing of very different institute regimes here, passing of key personnel, but it all sort of realized that you are investing reasonable efforts and a firm continuous determination, and you must have purposes for it and apply it constantly. And it requires also that you are able to foster the continued commitment of the providers of the sera. Of course, it has a bias towards the unwell, that was also discussed yesterday. But I think that experience tells that effect may be overestimated, that it turns out that they are pretty representative of the population anyway, in terms of the immunity. So, looking forward, our primary strategic objective actually is to continue to survive and preserve the core approach so that we can maintain a comparable data set through also the future decades. And we try to exploit and capitalize on the historic data and materials for long perspective analysis. We would like to evolve to develop in ways that maximizes the usefulness for knowledge and public health, with targeted studies and with more panoramic studies that exploit the long-term scope of our approach, and more collaborations, more sophisticated data analysis, and of course to expand to and evolve the laboratory methods and to other aspects of immunity. We would also like to expand by reaching out and advocate for comparable serosurveys from other countries. And it's wonderful to hear about all the things that you're doing in Canada, and expand to more pathogens, and to make use of the potential synergies with more sophisticated studies, like I've been saying. So I'd like to acknowledge the laboratories that are supporting us with the sera very, very faithfully through all those years, and to people in the center when I work, and then also the wider SARS-CoV-2 sera epidemiological team that we were collaborating with during the pandemic and are continuing to collaborate now. So thank you very much for your attention. Happy to take questions.
Thanks so much, Olaf. Wonderful insights on a terrific tradition and legacy, which I think survive, expand, evolve, and complement are very, very useful for all of us. We'll now move on to Dr. Hans Zeiger, please.
see my screen?
We see your screen well and just need your presentation mode. Perfect. Yep.
Yeah, is it filling the entire screen? Okay. Thank you for inviting me, dear colleagues. My name is Hans Seyer, as said, and I'm the senior microbiologist of the Dutch Blood Transfusion Service, which has a weird name, Sanquin. The G was already taken, hence the Q. We are the National Blood Service. Here you see the number of donors that are so kind to donate each year. And relevant for you to know is that by law we maintain a repository of each donation, PCR grade plasma, for at least 2 years. So we have at least 1.5 million samples on each moment of the previous 2 years of all donors throughout the entire country aged 18 to 80. And in the next, I think, 15 slides, I will give you an impression of 3 of our surveillance studies that we had to do by necessity. So I've limited time, so I cannot go in depth, but I hope it is inspiring for you. In one of my children's books, this is a picture of a Dutch farm. As you see, several species, low numbers of cattle, happy people. But in reality, this is a Dutch farm. And I think it's safe to say that Holland is has the most intensive animal farming of Europe and maybe even in the world. And we receive many blessings from this hyper-intensive animal farming, such as omni-resistant E. coli, H7N7 flu, MRSA, but also the next 2 outbreaks that I will show you that came from that intensive animal farming that we as a blood bank had to deal with to protect the safety of the transfusion in Holland. Unfortunately, in 2007 up to 2010, we had the largest outbreak of Q fever. That's an atypical pneumonia caused by inhalation of airborne spores of a small bacterium, Coxiella burnetii, in the world. There's not one other outbreak of Q fever that even comes near the outbreak that we had to endure in Holland. Here you see the number of weekly notified cases. And in 2007, a general practitioner in the south of Holland, because it took place in 2 provinces in Holland, in the south of my country, in Brabant and Limburg, he got worried and warned the authorities, and then a very strange thing happened that in hindsight, it was officially studied what happened and how it could happen. And to make a long story short, for 3 years, it was in fact decided not to do anything about it because nobody wanted to hurt our export of the enormous amount of, for example, goat milk to the rest of the EU. So nothing happened. People fell ill, but we at Sanquin got worried because we had a report of transfusion-transmitted Q fever in a setting with only very, very sporadic cases. So by necessity, we started an enormous intensive study. We had to pay it for ourselves because the government thought it was a non-issue. So in the 2 affected provinces, we collected 40,000 sera of all donors in the affected areas. And in the hottest areas, we applied this serology, a cheap ELISA, to all of them. And if it was slightly reactive, strong reactive, we confirmed it all by immunofluorescence. And to our amazement, we found out that per year, 6% of our donors seroconverted as confirmed by immunofluorescence for Coxiella burnetii infection. That was very worrisome because that means that the donation made in these areas could at any time be in the incubation time or in an asymptomatic carrier of the bacterium. So, and that was true. As you see, we had to develop our own PCR to screen donations, which is difficult to find the bacterial DNA in peripheral blood, but we succeeded. And in the most affected areas, 3 in 1,000 donations were positive for DNA of the bacterium. So by necessity, we had to do this. So first stage was serosurveillance, and followed by PCR development. And then fortunately, I cannot go to the next slides. What's happening? Yeah, there we go. Finally, the government stepped in because there were too many people in the hospitals. And in fact, it was solved very rapidly subsequently. Simply the culling of all infected herds, the vaccination of all healthy goats, because there's a vaccine, and the ban of transporting goats in Holland quickly solved the problem and it was never seen again, thank God. The second blessing, it's still going on. A few years later, we found out that immune-suppressed patients in Holland sometimes developed a strange, silently creeping chronic hepatitis that could result into death by cirrhosis and liver failure in a few years. And that was caused by porcine Hep E virus, a pig virus. Now, at the upper right-hand part of the slide, you see how many Dutch people are living in Holland and also the number of pigs. Nearly 1 pig per person, but each year again we produce 12 million pigs for the rest of the EU. And indeed, more than 95% of all piglets acquire Hep E virus infection. And that, of course, is such a high infection pressure that at the time they go to the slaughterhouse, that's already after 1 year of age, 1 in 10 is viremic. So all liver, all meat is viremic in enormous quantities. That was known, but again, and that's in fact still true up till today. There's no research going on how, in fact, the virus is transmitted from pig to patient. But so again, we stepped in also because we were afraid that many of our donors were silently carrying the virus. For example, one of our technicians took the bike, visited the supermarkets in the vicinity of the central lab of the Dutch Blood Transfusion Service. We do that each few years. So this is a few years old, the lower left corner of the slide. Maybe you can see my mouse, the sausage, some pâté, and here you see the Hep E RNA loads that are present in these foodstuffs from the supermarkets. 80% of those foodstuffs are positive. 80, but I must be honest, the majority are only incomplete RNA fragments. Approximately 1 in 4 samples concerns complete viruses, so that's only 1 in 5 sausages. Up till today, food may contain porcine Hep E virus in Holland, but the blood should be safe, and maybe that's a reasonable approach, thinking that most Dutch people, of course, have an intact immune system, and then you're not vulnerable for this virus only if you're transplanted or a hematological patient. Here you see the results of that screening. This is molecular. I shall come to, in a moment, I come to serosurveillance. Here you see the yield of the PCR. So the peak year was 2014, that each day we had 3, 4, or 5 viremic donations, and then it went down, and now it's coming up again. We don't know why. If you see this graph, you might assume, well, this virus seems to have been introduced maybe around 2010 in the pigs and then jumping to humans via the supermarkets. That seems reasonable to assume, but in comes serosurveillance, and we are in the happy circumstance that we not only have that 2 years repository of recent donations, but we also have a very special research storage of donations of the western part of Holland, which covers the 70s of the previous century up to 2000. So many decades we can study. And here you see what we did. We went back to those very old frozen samples, and we find very surprisingly that there probably is an age cohort effect. You see that if you only look at the oldest donors, the cohort between 60 and 75, the right-hand part of the slide, that in 1988, 2012 to 2023, seroprevalence is rapidly going down. So, in other words, you could say the curves are sliding to the right outside of the screen. But you see another effect in the younger donors, the donors aged between 18 and 30, the left part of all the graphs. Initially, it went down from 1988 to 2000, but then it's increasing again. So that means that Hep E returned, and that it was even much worse, much more highly infective in Holland, maybe around World War II. So maybe this is even a cycle that once every 50 years Hep E is visiting us. I don't know. But anyhow, the previous slides which would suggest a recent introduction, yes, that's true, but it was much worse in the past. Now I jump to the last part, the third example, maybe the most relevant, because I hope for you don't have Q fever or Hep E, porcine Hep E in your country, but we all do have corona. Early in the outbreak in 2020, our government asked us blood bank our blood bank to cooperate and to provide them with a nationwide sampling of 18 to 80-year-old donors of all postal codes, women and men. How many of them had already acquired infection in 2020? Of course, you could establish that by simply measuring the spike antibodies. But at the end of 2020, vaccine became available. So if you had spike antibodies, it could be because of acquired infection or by vaccination. So we added the nucleocapsid antibody test, nicely demonstrating the, for example, the occurrence of Omicron at the end of 2021. Then the infection proportion went up rapidly. Here you see the same graph by age. There are some few nice effects hidden in these graphs. For example, if you look at the spike antibodies, the older guys were vaccinated first. So purple goes up first, but in the right-hand bundle of graphs, the guys like me avoid infection until the very end. So there, the purple graph is the slowest to come up. But this is old, and you probably have the same in your own country. This is a little bit more special. Each cross-section in time concerns people without nucleocapsid antibodies. So they are only protected by vaccination. I come back to the quality of nucleocapsid antibody test as a marker for real infection. Here you see a few nice things. First of all, we could warn the government here in December 2021 that the vaccination levels, and at that time virtually everybody was only protected by vaccination in Holland, few real infections, was really going down rapidly. So with priority a booster vaccination was organized, and it was just in time in the snotty season in Holland to prevent a large outbreak of corona in people with very deeply waned spike antibodies. So far, so good. There are now hardly any people left without true infection, but there's another strange phenomenon in this graph. You might think these blips are randomly distributed, but please take a look at this. I hope you can see the mouse pointer, and you consistently see this dip in all the curves, and we call it the AstraZeneca effect. Only guys between 60 and 65 at the time, I was one of them, was invited to go to general practitioner for one shot of AstraZeneca before the RNA vaccines were available. So very weird phenomenon, only interesting from a scientific point of view. If you had one AZ shot years ago, and all vaccinations ever since were RNA-based vaccines, also in my age cohort, but you can still see the spike responses in people who have not yet acquired a real infection are still lower, even many years later. Now I think I come to my last slide, and maybe the most interesting for you. Here you see two brands of nucleocapsid antibody assays applied on a large group of donors that acquired infection very early during the pandemic, early in 2020. We follow them to study how their antibody levels against spike and against nucleocapsid protein are going. And the upper assay by Roche is very sensitive. You see above the red line is a positive test result. And you see the signals a little bit going down, but they stay positive, and here Omicron, and they go up, booster effect by reinfection. And you see the Abbott assay going down very rapidly. Now you can find national reports of EU countries that report their rough estimation of citizens' proportion with acquired infection based on this assay, the Abbott assay. But this assay wanes so rapidly that in fact you are only reporting the proportion of citizens in your country that experienced infection in the last year. So that's not cumulative at all. Then you could reason, so this is not a good assay because it turns so rapidly negative, and this is the superior one. Yes and no. We just found out that the Abbott assay, which wanes very rapidly and turns negative within a year, so to say, is very well for another purpose. You see here below the negative positive line, where's my mouse? Here it is. You see the reinfections by up climbing signals, and you see all the time people who go up and down. There are even donors who experience 4 up and down episodes. Now it's impossible to analyze this by hand, so one of the senior scientists in my group wrote an R script, and he asked the computer to select the donations of this group of donors where suddenly there is at least 2.5-fold increase of nucleocapsid antibodies. And we arbitrarily decided that is a criteria for reinfection. Of course, you don't know when the reinfection occurred. So again, arbitrarily, we decided that it would have happened halfway between the donation in which the antibody level was still going down and the donation in which the antibodies are going up. And then you get this graph. Here you see the percentage of the incidence of reinfections, and 100% per donor year is if all donors in that year experience one reinfection. And you nicely see an enormous number of reinfections, more than one per person with Omicron. And now it's fresh, it's still wet. A few days ago, I received the national monitoring of SARS-CoV-2 RNA loads in Dutch sewers. It appears that each day for more than 3 years, countrywide, the level of coronavirus RNA in the Dutch sewers is being measured. And they sent me the data set. Here it is. Each light green blob is the average level of coronavirus RNA on that day in our sewers. So I applied a sliding average with a window of 19 days, and that is the dark green curve. Now, if you doubt that orange curve, based on the increasing nucleocapsid signal of at least 2.5-fold is a good indicator of reinfection, maybe then the last slide is very hopeful. Now I superpose the green curve on the orange curve, and it's too good to be true. This really seems to correlate. Even the zigzags that you would assume to be artifacts seem to be present in both curves. So if this, of course, we have to look deeper into this. It's just yesterday evening I made this picture for you. But if this would be true, then you could have a very cheap, simple tool to estimate the number of SARS-CoV-2 reinfections in your population by simply applying a cheap nucleocapsid antibody assay on serial samples and determine the increasing signals as a marker for reinfection. Ladies and gentlemen, this has all been done by my wonderful team with these people, and I thank you very much for your attention.
Thank you very much, Hans, and you'll be glad to know that we're not serving any porcine products from Holland at our meeting. But fascinating work, and thank you for sharing it and to your colleagues. We're going to move now to Helen Ward. Helen, over to you.
Oh, I'm still disabled from sharing.
Okay, we'll just enable you here.
Thank you.
Okay, you should be enabled.
Yep, I am now enabled. Can you see that? Can you see my screen?
No, we see dark.
Let me go back.
Yeah.
Let's go back.
We have a frame, but no detail.
Okay, let's see.
Oh, it's not sharing yet. So maybe it's just making
Okay,
its way across the Atlantic.
It says it's failing to share. Okay, let's try again. Share screen.
Oh, it's coming.
Is that better?
There it is. Perfect. Yeah.
Excellent. Okay.
Just
all right.
Made it through Canadian immigration.
Usually takes a while. Okay, so thanks for the invitation to speak today. And I'm going to be talking about a specific study that I think just gives an insight into a slightly different approach to those that we've heard about yesterday and today, which was a mass testing using self-testing that we did in England in the pandemic, in the SARS-CoV-2 pandemic. So I just want to go through the methods and what we learned from this, and think that basically to open up a discussion about whether or not this kind of approach is something complementary to the residual blood screening and specific studies that we've heard about so far. So I have no conflicts to declare. So I'm going to talk about the REACT study. So the REACT stands for Real-Time Assessment of Community Transmission, which was a study that we rapidly mobilized in April and May of 2020 in response to a request from government to do surveillance in the community, so to get a random sample of the population and of sufficient size that we would be able to estimate the prevalence of the virus in the community using PCR testing with self-collected swabs. This is all done from people at home. That was the REACT-1 study, but I'm going to talk about the REACT-2 study, which was linked, where we invited people and sent out self-testing kits that Maria mentioned earlier, some of these self-test kits that emerged in March 2020 and of varying quality in terms of their ability to detect antibodies. So I'm just going to talk about REACT-2. So this study went from data collection from June 2020, so we mobilized very rapidly, to May 2021, and there were 6 rounds. This was a community study, so it was a random sample. In England, we have a National Health Service list of individuals which covers well over 99% of residents. Individuals are on that list, and we were able to get a sample of that and invite people by letter from all local areas in England, so over 200 local areas. People were invited to complete a registration either online or on the phone, and on doing so they were sent a kit. They were asked to perform a lateral flow test using finger prick blood, to complete a questionnaire, so this was a sort of sero-behavioral study, and to inform us of the result, and also to upload a photograph of the completed test. And over the 6 rounds, over 900,000 people tested themselves and reported a result that was valid, i.e. it wasn't an invalid test result. And through doing this, just wanted to share with you that quite a lot of what's been talked about so far is using retrospective samples collected for another purpose. Once we sent out invitation letters, within 2 weeks, we could have results from about 90 to 100,000 people. So there is something interesting in terms of the speed and scale that you can do a study like this. Obviously, I'll talk about some of the downsides in terms of the testing itself and the results itself, but it does have a lot to recommend it in some ways. So in order to do this, we recognized that we had to make sure that we were getting reasonable results and that people would accept it. So the first bit of the study that we did in April, before we actually rolled it out nationally, we were assessing the usability and acceptability to people of using these self-tests. So in the first month, or in fact in the first week after we received the tests and decided we were going to do this study, we did user testing in over 300 public advisors. There was a network of advisors that we have already in my research group. And then we rolled out a pilot to 14,500 randomly selected adults in the population. Over 98% of those who registered attempted the test, almost all of them completed, and over 94% reported a positive or negative result. And we found very high concordance with clinician-read results in this early study, where we were able to look at all the results ourselves. And the feedback we got from this engagement exercise enabled us to improve the kit. Some people had problems with the lancet not working, or the pipette to transfer the blood from the finger prick to the device, and we improved the instructions. We also, in parallel, carried out evaluation of the tests. We actually evaluated 5 tests, and you can see the results on the right here, just showing the sensitivity here. And those different tests had, apart from the WANFO, which was woeful. Most of them had reasonable sensitivity and higher specificity. We did this evaluation on people. We used local healthcare workers at the hospital where the university is based in Imperial, 270 healthcare workers who'd had confirmed infection, PCR positive, 30 days or more prior to collecting the blood sample. And we asked them to perform the test themselves, and we also collected blood to do a serological test on them for using an ELISA. And we also used 500 pre-pandemic stored sera. So we had most of them were highly specific, but variable sensitivity. And we selected the Fortress lateral flow immunoassay, which has a coronavirus structural spike protein target, which has the limitations that we've just heard about from Hans in terms of once vaccination came in, we were only able to measure the prevalence of either infection or vaccination, but not distinguish the two. And we compared it to in-house ELISAs and Fortress tests. We also did various other studies. I'm just showing here that we used live virus neutralization to check the validity of this, and we had reasonable results. On the left here, we've got the association of the lateral flow results with microneutralization in healthcare workers, and on the right, it was in people who had been vaccinated, showing that although there were some false negatives, there were, it was reasonable in both post-infection and post-vaccination situations. This was later on, we actually compared, we asked people who were performing the test on nearly 4,000 people to also provide us with a serum sample, again, self-collected at home. And so we were able to do a quantitative assay, looking, because we were finding a lower prevalence once vaccination came in, we were finding a lower prevalence of antibodies than those done using serological assay, using blood-based serological assays. And what you're showing is that there's less sensitivity with the LFIA than there would be, so that at this point, virtually everybody, if you use this was a Roche assay, virtually everybody was testing antibody positive, whereas at our cutoff we had a lower prevalence. We went through a lot of work with public and with public advisors on how to advise people to report the test. We then followed that up with developing an automated lateral flow analysis using machine learning and a computer visual device on the photographs that people sent us. And we used nearly 600,000 test photographs, and we found substantial agreement with the human experts on reading the test. The alpha automated did do better than the study participants, but we found that was particularly where there was a weakly positive IgG result, which was happening in people who had probably waning antibodies over time. So I'm just going to say a little bit about the results that we found to show although it's not a perfect laboratory-based test, we felt that we were able to get a lot of useful information for effectively serosurveillance in an emergency situation, and something that we could consider as a model for future ongoing surveillance, because you're able to reach large numbers of people relatively efficiently in a short space of time. So the first round, which was in June 2020, 6% of people reported a positive. That was our weighted estimate based on differing response rates. 6% antibody positive, and across the top, these are the different rounds going. So pre-vaccine is the blue ones, so 6, 4.8, 4.4, which shows decline in antibody. I think, as other people mentioned yesterday in the meeting, they find that after the first very large outbreak of the pandemic, in the spring of 2020 to find that only 6% of people had antibodies was a bit of a surprise to some people. That then declined over time, which people were saying, well, it can't decline, but it did decline, showing it was an early demonstration of waning antibody at the population level and not just in people who had been hospitalized, and which had been also shown in healthcare worker cohorts. Then we started to see an uptick with the second wave of infections, and then we saw the increase with the with vaccination rolled out at the end of 2020. Overall, our response rate was 29, just between 29 and 30%. So it's not perfect, but it's like all of these studies. However, it was reasonable, we thought, for a sort of cold calling letter that were people. So key findings, I'm just going to go briefly through the findings. First of all, we were able to estimate the scale of the first wave because we had, age-specific prevalences, and we were able to adjust for age, for sex, for deprivation. We were able to actually look at the variation. So the first round of 6% prevalence, we estimated that 3.4 million adults had antibodies by July 2020, and we documented variation by geographical region, age, ethnicity, work type, deprivation, and household size. We were also able to estimate the infection fatality ratio, which was just under 1%, 0.9, and to estimate that by ethnicity. And because there was a concern that people of Black and Asian ethnicity in England were much more likely to have severe infection and to die. And actually we found, well, through our work, it suggested actually that was due to being more likely to be infected, often because of occupation and socio-demographic factors, and that once you adjusted for age and gender, actually the IFR was the same. We asked people who'd had symptoms, when they had symptoms, and through each round, so these are the different blues are the different rounds, we asked people to say when they think they had infection, and we very closely tracked the shape and the timing of the curve that we got, that you'd get if you looked at hospitalizations, which were slightly later, and deaths, which were slightly later still. The second key finding I've mentioned is waning of antibody prevalence between June and September 2020, a fall of a quarter, 26% over 3 months. And the biggest decline in antibody positivity was in those older people and those who'd had asymptomatic infection. There was no decline in healthcare workers, which we suggest possibly that was repeat exposure or very high initial exposure that they will have had. Third key finding is variation in antibody response to vaccination. So the graph on the left shows all participants in grey. The lighter blue is the Pfizer-BioNTech or BioNTech, and the AstraZeneca is the darker blue. And this just shows over time. So following reported vaccination, you get a steep rise in the antibody prevalence or positivity. This then declines so that by 3 months, it was quite a lot lower, which is when the second vaccination was, and then it rises to around about 100%, but is consistently lower with the AstraZeneca vaccine. And on the right, this just shows the difference that people who had prior exposure in the dark here started with a more rapid and higher response, so if they'd had infection before, whereas those who hadn't had infection had a lower response and a more rapid waning. And the fourth final finding is that our result was associated, because we did this as a research study. It's surveillance and research. Again, going back to what Maria said earlier, there's an overlap here. But as research, we were collecting information from people, and we also asked people for permission to for record linkage to their National Health Service routine data, and also for permission to recontact people if we wanted in the future. So we've effectively established a cohort of overall of just about 3 million people that we're following up with details of their history of COVID-19. With this, we were able to look at people who tested negative on this self-test, this finger prick test, whether or not that was associated with a different outcome than those who tested positive. People were very concerned, particularly those who had COVID-19 or who had been vaccinated and remained negative. You could say that's because our test wasn't very sensitive. However, it was associated with, if you were negative, it was associated with an increased risk of hospitalization with COVID, almost threefold increased risk over the next 6 to 9 months. And it was increased death and increased specifically with death from COVID as the underlying cause. Now, some of that is due to the fact that people who don't mount an antibody response are sick. And so we have to, there are other explanations for this, but certainly it was picking out people who were more vulnerable to future infection. The implications, I would say, of this is that we've demonstrated on this very large scale a high feasibility and acceptability of at-home self-administered tests. It's reliable, cost-effective, and we can do it rapidly and at scale. It allowed us to estimate the size and distribution of the first wave of the infection and identify the most disadvantaged groups. And we were able to assess infection fatality ratio. I think we're among the first to document the widespread waning positivity following infection, and therefore to puncture the idea that there was going to be, we were going to get herd immunity following everybody getting infection once. We have been able to establish a cohort for future research and the long-term impacts of the pandemic on people's health, and that the antibody test result was associated with future risks of hospitalization and death. And in conclusion, I do think this is something to consider in an emergency, using self-testing. It did engage hundreds of thousands of people in this. People who took part were and continue to be very enthusiastic. The technology now facilitates self-testing. In a pandemic, you don't want to be asking people to go and take blood samples or come to healthcare facilities. We engage the public throughout this. Of course, response rate is an issue. And by adjusting for age, sex, and area, we were not able to fully overcome participation bias. But as we published our methods in the American Journal of Public Health last year, and the editorial that accompanied did say that the REACT-2 study, which using at-home self-administered tests provided with that information on seroprevalence was produced within days. We believe that giving more weight to population-based surveillance systems is needed. So I'd just like to echo that, and thank you for listening.
Thank you so much, Helen, and thank you to all our presenters. We're at time, and I know that you've provoked all sorts of questions. I think we're going to have to take those virtually, so we'll encourage people to contact you with their questions. But I think you've provided us just with an incredible feast of context in 3 different settings, with a huge historical perspective going back to the Russian epidemic, looking at the zoonotic interface, and then thinking about the importance of the population-based approach as perhaps a complement, or having speed and other efficiencies that might not be as easy to get in other systems. So really, really fantastic, and thank you so much for sharing them, and we look forward to following up and learning more. So with that, we're going to move to a coffee break here for only 15 minutes now. It's probably 14 because we have another panel starting at 10:15. Again, thanks very much to our panelists.